All right. So the topic we are discussing is hypertensive disorders during pregnancy. जहाँ पे आपको we have the 5 types: gestational hypertension, called pregnancy induced hypertension, preeclampsia, eclampsia, chronic hypertension superimposed with preeclampsia. So these are the 5 types. Okay. Now the question is, what is the diagnosis of gestational hypertension? So according to the ACOG 2023 guidelines, the diagnosis of pregnancy induced hypertension is that the systolic blood pressure should be more than 140, or the diastolic blood pressure is more than or equal to 90. So either 140 or 90, whatever, is occurring after 20 weeks of gestation. So this is what we all know. See, 20 weeks के बाद होना चाहिए. It should not be more than 20 weeks. But this pressure, okay, this elevated blood pressure, either systolic or either diastolic, in a patient who is more than 20 weeks of gestation, it should be measured or at least 4 hours difference. So you have to take measurement on 2 occasions and with at least 4 hour difference. So this is our MCQ question. This is the newer question. So 4 hour difference is important. BP 140 or 90, whichever is there, measured on 2 occasions at least 4 hours apart in a patient who is 20 weeks of gestation. Okay, and there will be no proteinuria, no organ dysfunction. I'll write it in short: P for proteinuria, OD for organ dysfunction. So there is no proteinuria, there is no organ dysfunction. If there is a proteinuria or organ dysfunction, it goes and become a preeclampsia. If you have seizures, then it is eclampsia. So the elevated blood pressure without the proteinuria and organ dysfunction is PIH. With proteinuria, organ dysfunction is preeclampsia, and with seizures, it is eclampsia. Now, the management part. Okay, so how we will manage this? So first of all, a PIH has to be classified between a mild and a severe variety. How is the mild variety diagnosed? Less than 160 by 110. If it is more than 160 or equal to 160 by 110 millimeter of mercury, it is severe. So there are only 2 categories of PIH: mild and severe. This is the diagnosis. How to diagnose mild and severe? Now, what is the treatment for mild? You should start only aspirin, low dose aspirin, 81 mg. But India doesn't give 81 mg tablets. We have 75 mg tablets of aspirin. And check the fetal well-being and deliver at 37 weeks. So delivery at 37. So ये तीनों के तीनों क्वेश्चन आ सकते हैं. Should you start antihypertensive? The answer is no. We don't start antihypertensive in mild PIH or gestational hypertension. What is the definition of mild? That has to be remembered. What is the treatment? Low dose aspirin, 81 mg daily. Okay. Check the fetal well-being and delivery at 37 weeks. So this is a question: when to deliver, at 37 weeks or after. When it is severe, it is 160 or 110, then you start the patient on antihypertensive. 3 antihypertensives are recommended: labetalol, nifedipine, and methyl-dopa. I'll short write it: methyl-dopa, labetalol, nifedipine, and methyl-dopa. And monitor if the patient progress to become a preeclampsia patient or not. And you can give MAC sulfate if there is a risk. And what is the time for delivery? 34 weeks. Deliver after 34 weeks. If there is no fetal distress, go with 34 weeks. If the patient has a high blood pressure, 34 weeks में delivery कर दो. इसके बाद बात ठीक है. But if there is a fetal distress or there is a maternal distress, in that case all these 37 weeks 34 weeks guidelines all go wash away. So जब तक कुछ हो नहीं रहा है, 37 weeks for mild, 34 weeks for severe PIH. But if something is happening to the mother, if something is happening to the baby, then there is no time for you. तो आपको deliver करना ही पड़ेगा उस वक्त. In both these patients, okay, you have to check the blood pressure even after delivery. So even after delivery, Up till 12 weeks you have to check the blood pressure. If the blood pressure continues to stay after 12 weeks, then the diagnosis is now changed. It is no more a gestational hypertension, it is a chronic hypertension. That means you missed it. Actually patient को पहले से ही hypertension था. The patient came after 20 weeks or maybe before 20 weeks, you are not able to diagnose it, आपसे मिस हो गया. तो अगर 12 वीक्स के बाद भी ब्लड प्रेशर बढ़ा हुआ है, then it is a chronic hypertension. Because in PIH, in eclampsia, short P, preeclampsia and eclampsia, in all these three, the blood pressure should fall down within 12 weeks after delivery. If the patient's blood pressure continues to stay elevated even after 12 weeks of delivery, then your previous diagnosis is wrong. It's a chronic hypertension. अगर preeclampsia develop करा था patient को, then it was actually a chronic hypertension superimposed with preeclampsia, or a chronic hypertension superimposed with eclampsia. So that was your diagnosis which you missed and diagnosed as just PIH or PE or eclampsia. Labetalol is the one that is most commonly preferred. Now labetalol we all know is a beta blocker, but is it something else? Yes, it is not just beta, it is also alpha blocker. It is beta plus alpha blocker. Selectively speaking, it blocks beta 1, beta 2 and alpha 1. In patients with PIH, what is the starting dose? Basically, obviously for severe PIH, you give 100 mg BD to the patients. Okay, labetalol you give 100 mg BD. So that means you can give 200 mg per day. You give 200 mg per day as a starting dose, but the maximum dose is 2400 mg per day. So see कितना बड़ा रेंज है इसका. 200 mg starting dose यानी कि 100 mg करके BD, but the maximum dose is 2400 mg. But suppose if you are supposed to give when the patient comes with hypertensive emergency, okay, in this case, so in hypertensive emergency, sorry, I was disturbed by my dog. Hypertensive emergency, you have to give 20 mg IV. Okay, this you have to give over 2 minutes. 20 mg is the starting dose. You give over 2 minutes. Wait for 10 minutes. Check the blood pressure. If doesn't work, give 40 mg IV over 2 minutes. Check for another. Wait for another 10 minutes. Check the blood pressure. If it doesn't come down, give 80 mg over again 2 minutes. Again doesn't work, then so to again wait for 10 minutes. If doesn't work, give 150 mg now. Okay, and if it doesn't work, give sorry और ज़्यादा नहीं देना है आप अभी सॉरी अभी आप दोगे. हाँ, टोटल डोज 300 mg करना है, तो इसके बाद आपको करना है एक और 160 mg का डोज देना है आपको ओवर 2 मिनट्स. टोटल डोज हो गया आपका 300 mg. So 20 plus 40 plus 80, 20 plus 40 60, 60 plus 80 is 140, 140 plus 160 300. Yes, so total dose is 300 mg. You can give maximum total dose of 300 mg. और ऐसे करके आप दे सकते हो 20 mg पहले दिया, फिर 40 mg दिया, फिर 80 mg दिया, डबल कर रहे हो, एंड देन 160 mg दिया, टोटल 300 mg दे दिया. इससे ज़्यादा नहीं दोगे. कैसे देना है? 10-10 मिनट के गैप में, और हर बार ओवर 2 मिनट्स, ओवर 2 मिनट्स. बिकॉज इट्स अ बीटा ब्लॉकर, तो आप कहाँ पे नहीं दोगे? COPD और एजमा पेशेंट्स में, हार्ट ब्लॉक, ब्रैडिकार्डिया पेशेंट्स में, क्योंकि बीटा ब्लॉकर है, एंड इन अ डीकॉम्पेंसेटेड हार्ट फेलियर पेशेंट्स, बिकॉज आप डीकॉम्पेंसेटेड हार्ट फेलियर में बीटा ब्लॉकर दोगे तो ख़राब हो जाएगा. बिकॉज इफ़ यू गिव 300 mg, अगर आपने अगर 300 mg labetalol दिया है, so you know it's a very strong beta blocker. It will cause decrease in the heart rate. So this will not just affect the mother but will also affect the fetus. Okay, so check the fetal heart rate, because it can cause fetal bradycardia. Okay, remember labetalol can cause fetal bradycardia. No, the other drug methyl-dopa, see, it's a very very safe drug, but the problem is it is not as efficacious as labetalol. Methyl-dopa is good only for chronic hypertension. and if the patient is a PIH patient who is mild PIH, although in mild PIH we don't recommend ACOG 2023, हम नहीं 20 ACOG गाइडलाइंस बोल रहे हैं कि not to start antihypertensive, but if the patient has risk so you can start antihypertension, तो वहाँ पे आप दोगे मिथाइल डोपा, एंड क्रॉनिक हाइपरटेंशन में आप दोगे मिथाइल डोपा, बट फॉर प्री इक्लैम्शिया okay and for severe PIH and obviously for eclampsia also you will have to give labetalol. Now how methyl dopa works, तो थोड़ा सा आपको पता है कि डोपा में क्या होता है. तो सपोज दिस इज योर एडिनर्जिक नर्व एंडिंग, डोपा इज इनसाइड दिस. ओके, दिस डोपा विल बिकम फर्स्ट ऑफ ऑल डोपामिन, डोपामाइन मैंने शॉर्ट में लिख दिया, and this dopamine will become norepinephrine. This enzyme is dopa decarboxylase and this enzyme is dopamine hydroxylase. The same thing happen with methyl dopa, because it is methyl dopa, it will become methyl dopamine and then it will become methyl norepinephrine. When this methyl norepinephrine is released, I'll write in short, methyl norepinephrine, when this is released, this doesn't bind to the alpha 1 receptors in the postsynaptic membrane, rather goes and binds to the alpha 2 receptors, which are inhibitory kind of receptors. So they inhibit the release of norepinephrine, and that is how it works. Now these drugs that you are giving, labetalol do, methyl dopa do, or you give nifedipine. Okay, nifedipine, you know, it's a calcium channel blocker. Okay, now the target should be to keep the diastolic blood pressure more than 80. Diastolic, don't make it below 80. ठीक है, पेशेंट का डायस्टोलिक मान लो 95 था, या फिर मान लो कि पेशेंट का जो है शुरू में ब्लड प्रेशर था 160/90, ठीक है, और सपोज इट वाज 170/90. ओके, इट वाज 170/90 एंड यू डिसाइडेड टू रिड्यूस द ब्लड प्रेशर. ठीक है, तो आपका ब्लड प्रेशर घट के चला आया 140/76. So this is not desired. Okay, what is not desired? This diastolic blood pressure falling below 80. तो आपको क्या करना है, इसीलिए ACOG बोलता है कि BP गोल्स शुड बी लेस देन 150/100. इसके नीचे ला दिया, दैट्स इनफ. ठीक है, क्योंकि आप उतना टाइटेट करके 80 के आसपास नहीं ला सकते हो. राइट, आप 80 के नीचे नहीं, आप 80 के आसपास नहीं ला सकते हो सकता है कि 80 से ज़्यादा गिर जाए. तो बेटर है कि आप 80 से 100 के बीच में रख दो डायस्टोलिक ब्लड प्रेशर को. ठीक है, एंड सिस्टोलिक बीपी को आप लेस देन 150 लेके आ जाओ, दैट्स इनफ. कुछ नहीं होने वाला पेशेंट को. सो व्हाट इज़ द टारगेट बीपी, एंड टू अंडरस्टैंड टारगेट बीपी यू हैव टू अंडरस्टैंड दैट मोस्ट इंपॉर्टेंट थिंग हियर, कि डोंट ब्रिंग द DBP less than 80. Why? Because your uteroplacental perfusion will get hampered. So don't hamper the uteroplacental perfusion. Keep it more than 80 millimeter mercury, preferably 150/100. 150/100 से थोड़ा नीचे ला दो, that's enough. Now how do you diagnose preeclampsia? Obviously आपका कट ऑफ हुई है 140/90. ओके, 4 आवर्स के गैप. विद दैट आइदर प्रोटीन यूरिया और साइंस ऑफ एंड ऑर्गन डैमेज. प्रोटीन यूरिया मतलब क्या हुआ, यू हैव मोर देन 300, सो यू हैव टू हैव अ ओवर्ट प्रोटीन यूरिया. ओके, मोर देन 300 milligram ओवर 24 आवर्स, और +1 in urine dipstick tests. Okay, now end organ damage में क्या देखना है आपको? If you don't have protein urea, if you have signs of end organ damage like pulmonary edema, like you have patients have visual symptoms, pulmonary edema है और visual symptoms है, or if there is a new onset cerebral symptoms, visual symptoms, cerebral symptoms, pulmonary edema, You have features of renal insufficiency like serum creatinine going up, creatinine is going up, or you have features of impaired liver function like AST or ALT going 2 times of the upper limit of normal. So liver functions are getting impaired, renal insufficiency, or you have thrombocytopenia, platelets less than 1 lakh per microliter. So these are all criteria of end organ damage. Along with that, if you have raised BP, it's a preeclampsia. अगर प्रोटीनूरिया नहीं भी हो तो भी डायग्नोस हो जाएगा. पल्मोनरी एडिमा, विजुअल सिम्टम्स, सेरेब्रल सिम्टम्स, रेनल इंसफिशिएंसी, AST ALT एलिवेशन है यानी कि लिवर फेलियर का साइंस, मतलब लिवर फेलियर नहीं, लिवर डिसफंक्शन के साइंस, एंड थ्रोम्बोसाइटोपिनिया लेस देन 1 लाख. पैथोफिजियोलॉजी आपने बहुत बार पढ़ा होगा ऑलरेडी पहले कि दीज आर सपोज spiral arteries. Now these spiral arteries are narrow. What will trophoblasts do? They will make them broad. So this is done by trophoblast. So trophoblast is converting the high resistance spiral arteries into low resistance high capacitance vessels. So they are arteries but they are now becoming like a capacitance vessel, यानी कि एक वेन जैसा बन जा रहा है वो लोग. In case of preeclampsia, this remodeling of the spiral arteries by trophoblast is incomplete. Spiral arteries stay narrow, muscular and high resistance because the spiral artery ends at the intervillous space. So suppose this is a spiral artery, this will end in a space called intervillous space. मैं यहाँ पे बहुत ही गंदा डायग्राम दे रहा हूँ. So suppose there is a villi over here and villi over here. So this is a spiral artery and this is a villi and this is another villi. So in this intervillous space spiral artery will end. Okay, हमें इसको लो रेजिस्टेंस हाई कैपेसिटेंस वेसल बनाना है, जो काम है ट्रोफोब्लास्ट का. यही खराब है प्रीक्लैम्पशिया में. सो दिस आर बेसिकली एंड आर्टरीज काइंड ऑफ द वंस दैट सप्लाई दी इंटरविलस स्पेस. बेसिकली आते हैं यूट्रन आर्टरी से. यूट्रन आर्टरी से आपको सबसे पहले आएगा रेडियल आर्टरीज, उसके बाद आपके आएंगे आर्कुएट आर्टरीज और उसके बाद आएगा आपको स्पाइरल आर्टरी. ये उतना परफेक्ट एनाटॉमी नहीं है लेकिन आपको एक ओवरऑल आइडिया है कि स्पाइरल आर्टरी आ रहा है फ्रॉम दिस वे, यूट्रन आर्टरी टू रेडियल आर्टरी टू आर्कुएट आर्टरी एंड देन स्पाइरल आर्टरी. नाउ see one very big problem. See, suppose this is a placenta, okay, and this is the spiral artery. बस एक डायग्राम दे रहा हूँ मैं. स्पाइरल आर्टरी एक्चुअली जस्ट ये तो है नहीं, but suppose the placenta is getting supplied by this spiral artery. Now what are the factors which are supposed to make it low resistance high capacitance vessel? So these are basically your angiogenic factors like VEGF, okay, PIGF. VEGF तो पता है ना, vascular endothelial growth factor. PIGF is nothing but placental growth factor. ठीक है. So these are the angiogenic factors. They are supposed to make the placenta more vascular, bring more blood supply to the placenta. But the catch over here is when the spiral artery do not undergo the remodeling, so उतना ज़्यादा ऑक्सीजन सप्लाई नहीं हो रहा है. ऑक्सीजन सप्लाई कम है अभी, reduced oxygen supply to the placenta. Now this placenta is such a bastard, when it gets less blood supply it starts producing anti-angiogenic factors. You should produce angiogenic factors so that you get more blood supply, but when it gets less blood supply it wants more of less blood supply, it doesn't want more oxygen supply. So the anti-angiogenic factors like SFLT, इसका फुल फॉर्म काफ़ी टफ है, soluble FMS like tyrosine kinase 1, SFLT1, soluble FMS like tyrosine kinase 1, and SENG, soluble endoglin. So SFLT1 and SENG, soluble endoglin, and soluble FMS like tyrosine, kinase 1. These are anti-angiogenic factors. Now I was telling you about diagnosis of preeclampsia with proteinuria, without proteinuria, that is with end organ damage. If there is end organ damage, irrespective of the blood pressure, you have a severe preeclampsia. Okay, so severe preeclampsia diagnosis कैसे होता है? Severe preeclampsia, either of the two. Okay, so your preeclampsia is diagnosed. Okay, now if your blood pressure is more than 160 by 110, it's a severe preeclampsia. Or you have end organ damage, this is severe preeclampsia. Okay, but if you don't have end organ damage, you only have proteinuria and your blood pressure is less than 160 by 110, but has to be more than 140 by 90 obviously. So if it is less than 160 by 110 and there is only proteinuria but there is no end organ damage, then it is a mild preeclampsia. So severe preeclampsia diagnosis के सिर्फ दो ही criteria हैं, 1 and 2, BP and end organ damage. If either of the one is present, it is a severe preeclampsia. If neither of them are present, you have to diagnose whether it is preeclampsia or not. If there is blood pressure more than 140 by 90 and there is no end organ damage but with proteinuria, it is a mild preeclampsia. In treatment तो वही है हमारा antihypertensives, but what is the criteria of delivery? Just like your mild PIH, for mild PE, delivery at 37 weeks, and for severe PE, just like your severe PIH, delivery at 34 weeks. Mild PE, we give antihypertensives, but in mild PIH, we don't give antihypertensives. Only in severe PIH, we give antihypertensives. But here, we give antihypertensives, but we also start magnesium sulfate must in severe preeclampsia. What is the purpose of giving magnesium sulfate? So थोड़ा सा magnesium sulfate के बारे में जान लेते हैं. We all know it is for neuroprotection of the fetus. There are 3 regimens for it: Pritchard, Zuspan, and Cibai. In India, we give Pritchard because it's a resource limited state. Zuspan in developed settings, we give Zuspan. So most common is given Pritchard, which is 4 gram IV. This is important. 4 gram. Point number 1. Point number 2, IV. Point number 3, over 10 minutes. 4 gram IV, 10 minutes. Then 5 gram plus 5 gram in each buttock. Total 10 gram. So we are giving 4 gram IV and 10 grams in each buttock, and this is IM. So 4 gram IV, 10 gram IM, 10 gram IM, 5 gram in each buttocks. So this is the loading dose. Loading dose is 14 milligram, 4 gram, 4 gram IV and 10 gram IM. And after loading dose, maintenance dose, MD. Maintenance dose, we give 5 gram IM every 4 hourly in alternate buttocks. 5 gram IM 4 hourly alternate buttock. Obviously alternate buttock क्योंकि एक ही बटक में आप देते जाओगे तो दर्द हो जाएगा. So every 4 hourly is the clue, and again IM is the clue. 5 gram is the clue. 5 gram IM every 4 hourly alternate buttock. कंटिन्यू कब तक करना है आपको ये मैग्नीशियम सल्फेट? 24 आवर्स आफ्टर डिलीवरी। सो डिलीवरी हो जाने के बाद भी आपको चलाते रहना है फॉर द नेक्स्ट 24 आवर्स। द प्रिचार्ज रेजिमेन इज IV plus IM, whereas Zuspan is purely IV। यहाँ पे भी लोडिंग एंड मेंटेनेंस है, बट यहाँ का लोडिंग डोज बहुत ही कम है, ओनली 4 ग्राम IV, एंड मेंटेनेंस डोज इज 1 ग्राम पर आवर IV, 1 gram per hour IV. So you are giving 24 grams per hour, sorry, in 24 hours per day, 24 grams per day. So first loading dose is 4 gram IV and then 1 gram per hour IV. So Zuspan is completely IV. Always remember, you have to give the starting loading dose over 10 minutes. Here also, in Zuspan also, give it over 10 minutes. In Cibai, what we give higher loading dose. So it is a modified Zuspan regimen. It's a modified Zuspan regimen where we give higher doses. So Zuspan में हम लोग 4 mg दे रहे 4 ग्राम दे रहे थे IV, बट यहाँ पे देंगे हम लोग 6 ग्राम, because we are giving 6 grams, so we have to take more time. So 4 gram IV we were giving over 10 minutes, but 6 gram IV we will give over 20 minutes. Over 20 minutes we'll give 6 gram, and then we will give 2 gram per hour IV infusion. So it is a higher dose of Zuspan. 6 grams loading dose IV over 20 minutes and 2 gram per hour IV infusion. If the patient develops magnesium sulfate toxicity, the antidote is calcium gluconate 10%. So 10 ml आपको calcium gluconate 10% लेना है and give it IV. So you take a vial of calcium gluconate that contains 10 ml, that contains 10 ml of calcium gluconate 10%. This 10 ml vial you will give IV over 10 minutes. So you have a vial which contains 10% calcium gluconate and total dose is 10 ml. So you give this entire 10 ml IV over 10 minutes. Max sulfate toxicity होगा तो क्या होगा? Earliest is loss of patellar tendon reflex. Patellar tendon reflex is lost. So reflexes, respiratory rate, urine output, these are signs of max sulfate toxicity. Deep tendon reflex घट जाना, respiratory rate घट जाना, urine output घट जाना. You have to monitor these reflex, respiratory rate and urine output.